Kekada, sir?
Yeah, better, madam.
Yeah. So at the outset, I would like to thank
Better not
IIT
so well, so can keep the
CISC
mic a little nearer.
for asking me to chair this session. That too with stalwarts like Dr. Hemchand, that's at the Soundaram here. And I welcome both of them. And I'm sure we are going to have a very interesting discussion. But before we go on to the presentation, there are a few things that I would just give an introduction. Why is it that growth monitoring is so important in pediatrics? We all know that growth is an integral aspect of childhood. It's an indicator of health and well-being. We most often have children, parents who come and say, my child is very short, my child is not gaining weight. So in these situations, it is very important to mark a growth chart and tell them so that they are reassured that their child is growing within the normal range. So in those situations, it is very important in a normal child, but equally important is also to identify the various pathological states at an early stage rather than they become full blown, like children with growth disorders, children with nutritional deficiencies, children with chronic systemic illness, or children with other endocrine and other systemic illness. So it is important that we need to monitor growth. Now, having said that we need to monitor growth, we need to see how often should we monitor. Now, way back in 2007, there were guidelines by the IAP, which still holds good even today. So 0 to 2 years, we know we always measure the length, weight, and the head circumference at every vaccination visit. And between up to 2 years, we generally measure the height, weight, and head circumference every 6 months. But beyond 5 years, we generally measure only the height, weight, and the body mass index, including the SMR, ideally every 6 months up to 9 years, and after that, at least once a year. So we monitor the growth. Now, how and what charts are we going to use? Up to 5 years, we can use the WHO charts or the IAP modified WHO charts. 5 to 18 years, we generally use the IAP WHO chart. IAP also has the 0 to 18 years modified charts, which also we can use. Also, we should remember that there are special growth charts for children with Turner syndrome, with children with Down syndrome, achondroplasia, because we cannot mark them on the regular chart and say what the growth is like. There are also special growth charts for newborns and for preterm. So we all need to be familiar with all this. All of us will also be familiar with a simple pediatrician friendly chart. So which is okay for a busy office practice. So without calculating, just knowing the height, weight, and the parent's height, we can mark both the BMI as well as the target height. But that is okay for office practice, but students should definitely be using the IAP charts. So now that we know how to mark the chart and all the other anthropometric measurements, not just the height and the weight and the head circumference, we should also be calculating the upper and the lower segment. We should also be taking the bone age. So without doing all that, we can't really define a child as being short. So when do you say that a child is short statured? The height which is more than 2 standard deviation below the mean or the third centile for age, gender, and race. Ethnicity is very important because we cannot compare our Indian children with Western and say probably all of us will be midgets if we plot that way. Now, not just the height alone, but we also need to ensure that the height is anytime the height which is more than 2 major percentiles below the mid-parental height, that again is a child who is short. Or if the growth velocity is below the 25th centile for age and sex matched population, because we have growth velocity charts, and anytime a baby child crosses 2 major percentiles over a period of 1 to 2 years in older children or over a period of 6 months in infant. So with all these criteria only, we can say that the child is short. And we should never forget that familial and constitutional growth delays are still very common. Now, this is just a brief statistics from various studies in India. Now, hypothyroidism, a very correctable cause, seems to be a very common cause. And of course, nutritional deficiencies, growth hormone deficiency. So this is just to present the statistics which we thought, then the importance of dealing with short stature. So now I think without wasting too much time, we will go on to Dr. Sandeep to start presenting the case.
Yeah, before going that presentation, I would like to invite Dr. Hemchand to tell few words. Hemchand.
Good evening, sir. I think thank you very much for this nice opportunity. I think we have a very interesting case that is going to be presented by Dr. Sandeep. And to add on to the discussion, we also have two bright postgraduates, Dr. Mitra and Dr. Anvita. And myself and Dr. Soundaram, we will be discussing the case and trying to bring out the common exam-oriented aspects for the benefit of the postgraduates who are attending this session. Dr. Soundaram will be concentrating on the history. I'll be concentrating on the examination. Then Madam will be discussing about the investigations and I'll be discussing about the treatment. Thank you, sir.
Thank you, Madam. Dr. Soundaram, please.
Yes, sir. So the PG will be presenting the case.
Yeah.
Yes.
Just a few words from your side.
Okay. So thanks for the invite. So let him proceed with the case. So I'll discuss slide by slide, sir.
Okay. Thank you. Yeah, PGC, you can proceed for your presentation.
Good evening, all. Today we are going to see about a 6-year, 10-month-old female child who was brought with complaints of short stature by her mother, whose reliability is good. Child is not gaining adequate height since birth. That was her presenting complaint. And parents noticed that their child is not growing in adequate height since birth. She is also short when comparing to other girls and peer children in the same age group. Child used to sit in the first row in the class, and she is not outgrowing her clothes and shoes. When the mother compares the child with the younger sibling, she is much more shorter than the sibling. Weight gain is also low when compared to her younger child. And she also noted that the is also the case. Her molars itself developed after only 1.5 years of age.
Dr. Sandeep, we'll discuss the first slide and then we'll go to the next one. Yeah, so yes. From the onset of short stature, what are the clues you get towards the diagnosis? So this child, the mom has told that faltering of growth has happened during since birth, no? So what are the conditions where you think of short stature so early on in life?
Any child with intrauterine growth restriction, any prenatal insult can lead to low height and low length since birth. Then any intrauterine infections or child with a placental child born to the mother with placental insufficiency or any intrauterine growth, any factors that is causing intrauterine growth restriction can cause.
So you have to first assess whether it is prenatal onset or postnatal onset. So prenatal onset, like you told, it can be because of maternal nutrition, any placental factors or intrauterine factors, like if the uterus is faulty, like that. So those factors also contribute to prenatal onset. Apart from that, there are some things called as primordial dwarfism. So primordial dwarfism are this Russell-Silver syndrome, Seckel syndrome, Mayer-Gorlin syndrome. All these will be SGA at birth itself. So if you have a SGA at birth and they're continuing to have postnatal growth failure, so prenatal as well as postnatal growth failure, you have to think of primordial dwarfism. And some syndromes like Turner, Down syndrome and all, they will be AGA at birth and then they will have faltering later on only. And similar way, there is something called the ICP model. So ICP, do you know what is ICP model of growth?
No, ma'am, I don't.
Okay, so ICP is I stands for infancy, C for childhood, and P for puberty. So infancy, the major contribution towards growth is by nutrition. Okay, so if the child is malnourished right from infancy itself, their height and weight can be low. And childhood, C for childhood. Childhood, the major contributors are the growth hormone and the thyroid hormone. So growth hormone deficient children will usually have faltering after 2 years of age only. During the first and second year, usually their height will be okay, it will not be very bad. And hypothyroidism also classically presents during the childhood phase. The next P stands for puberty. So puberty, the main hormone which contributes is the pubertal hormone. However, the growth hormone also should increase during the pubertal phase. So both growth hormone and pubertal hormones play a crucial role during pubertal growth spurt. Okay, so this is how you can, you can get a clue towards the diagnosis based on the onset of short stature. Okay, so that is one thing. The other thing what you've mentioned here is delayed dentition. So when, what is when will you start working up a child for delayed dentition, and what are the common causes you know of?
Even when the child have no dentition, even after 13 months of age,
Okay.
you can consider it as delayed dentition.
Okay.
Common causes you can think about hypothyroidism, then hypopatriotism, and then vitamin D deficiency cause delayed dentition.
So these are the common causes you've told of. Apart from that, malnutrition also they can have, and some local dental pathology also they can have delayed dentition, HIV. So all these also can have delayed dentition. So most common as a PG you should know is vitamin D deficiency and hypothyroidism, as you told. Okay, so we'll go to the next slide.
Okay. To rule out systemic causes, we asked the following history. There was no history of inadequate dietary intake or pallor or pedal edema. There was no history of chronic diarrhea or low stools, no history of polyuria or oliguria or polydipsia. There was no history of recurrent LRA or wheezing, and no history suggestive of constipation, lethargy or weight gain or dry skin. No history of easy fatigability or lethargy. No history of bony deformity or recurrent fractures. There was no history of headache, vomiting, and visual disturbance.
Okay, can you just tell for what reason you've asked all this negative history, just for the benefit of the other PGs?
Yes. To rule out malabsorption, I asked about the chronic diarrhea and oily stool.
So chronic diarrhea and oily stools for malabsorption.
Yes, malabsorption and cystic fibrosis.
Okay, cystic fibrosis also because of pancreatic exocrine deficiency. Okay. Then the first line, inadequate dietary intake, pallor,
malnutrition.
Yeah, protein energy malnutrition, as well as all these malabsorption syndromes also can have anemia and hypoproteinemia, no? Which also lead to pallor and pedal edema. Okay. Third line.
To rule out renal tubular acidosis and then diabetes insipidus, I asked about polyuria and oliguria.
Okay. Oliguria is not for RTA and diabetes insipidus.
That's not. To rule out CKD, I'm sorry.
Okay.
Then to rule out immune deficiency, I asked about recurrent infections. And to rule out hypothyroidism, I asked about the symptoms of constipation, weight gain, and dry skin.
Okay, 1 minute. For recurrent LRI and wheezing, the other important thing is if they are chronic asthmatics on steroids also, this history becomes important to us. No? If they have recurrent LRI and wheezing, apart from that, cystic fibrosis also can have recurrent LRI. Okay, so any chronic disease as such, more energy is spent towards recovering from the illness, and there is less energy left for growth. So all chronic diseases you have to mention. Similarly, you could have also put for congenital heart disease, cyanotic heart disease, that symptoms also. Okay. Okay, so the next point, constipation, lethargy, weight gain, dry skin, excessive sleepiness, cold intolerance, all that for hypothyroidism. Okay, next slide.
And easy fatigability and lethargy to rule out adrenal insufficiency.
Okay, the main symptoms for adrenal insufficiency you should ask is energy levels that you've written by easy fatigability, I think. So is the energy level good or not? Other thing is postural giddiness. Children will commonly complain of giddiness when they will change position, and weight loss, vomiting. These are some significant symptoms you have to ask for adrenal insufficiency. Okay, so weight loss, giddiness, vomiting, and energy levels. Okay, the next line.
And bony deformity and recurrent fractures to rule out vitamin D deficiency, and then and skeletal dysplasias.
Okay, and osteogenesis imperfect also. Because of the deformity itself, they will be shorter. Okay, then.
And to rule out intracranial raised ICT and intracranial space occupancy lesion, I asked about headache, vomiting, and visual disturbance.
Okay, okay, and this also usually this intracranial tumors, they will have faltering of growth like in the recent past, like 1 or 2 years. Usually they will tell, the parents will tell that initially they were growing well. Last 1 or 2 years only we are seeing a faltering of growth. Okay, so the onset again becomes important here, because this is initially the child was well, and last few months or few years there is faltering of growth. Usually this history is seen with craniopharyngioma and all. Okay, so and apart from that, what is the visual disturbance that you will see in space occupying lesion around the pituitary area? What is the visual disturbance which is very characteristic?
Optic atrophy will be there. Ataxic gait due to blurring of vision.
No. See, ataxic gait is cerebellar involvement. Usually, if the chiasma, optic chiasma is involved, you will have bitemporal hemianopia. So the sides,
Okay.
both the temporal sides, they will not be able to see well. So when they're walking, they will get hit against the sides. Okay, so they will not know the wall, so they will hit against the wall. So you should ask the parents whether they're able to see the sides well or they are getting hit on the sides, because bitemporal hemianopia is the first visual disturbance which is known to happen. So more than the papilledema, you have to look for visual acuity testing in pituitary pathology. Okay, so visual acuity testing becomes important, and then papilledema you should ask your ophthalmologist to see. Okay, so we'll go to the next slide.
Past history, there was no significant systemic illness in the past, no history of recurrent blood transfusions or long-term steroid intake, no history of chemotherapy or irradiation or surgeries in the past, intracranial surgeries in the past, no history of tuberculosis infection in the past.
Okay, so you can proceed to the next one.
Antenatal history, except for the antenatal scan, abnormal antenatal scans, everything was normal. Fetal limb length was shown to be low since second trimester scans. Then they also noted polyhydramnios. Other than that, weight gain was adequate, pain was well felt, and no other significant illness was noted in the mother in the antenatal period.
Okay, so what is the most common cause for limb length shortening during the antenatal period? So what do we commonly think of when we see this fetal limb length shortening in the antenatal period?
We think about IUG, growth restriction.
Okay, suppose they say only the femur is short. They're telling you the fetal femur is short.
And a syndrome, Down syndrome.
Actually, they will be AGA. Usually, we think of skeletal dysplasias, commonly achondroplasia, when we see that the fetal limb length is short. Usually, these skeletal dysplasias can be picked up by second trimester scan itself. Okay,
Yes.
So you can go to the next one.
Then natal perinatal history. Birth weight is 2.8 kg. Birth length was said to be less than normal. There was no documents available. Mode of delivery is normal. No history of birth asphyxia, and no history of prolonged jaundice or hypoglycemia. The child was discharged on the day 4 of life. Presentation is cephalic presentation.
Can you go to the previous slide? We'll just finish it. So from the presentation, what is the clue you will get? If the child was a breech presentation, will you think of a diagnosis?
Hypopituitarism.
So hypopituitarism, they are known, like most of the children will be breech presentation. That's correct. And what are the symptoms you will get for, like if the child has hypopituitarism, what will be the symptoms which will be there in the perinatal period?
And, neonatal hypoglycemia.
Yeah, hypoglycemia. Okay.
And prolonged jaundice due to
prolonged jaundice. Okay. Yeah, these two only. So prolonged jaundice, hypoglycemia will be there. So you have to look for that. Apart from that, okay, so feeding difficulties, actually feeding difficulties is one clue. In the infancy, if there is feeding difficulties, suppose the baby was a SGA baby and had feeding difficulties in the first year of life and hypoglycemia also, then what will you think of? Some syndromes can have feeding difficulties, no? Prader-Willi syndrome, yes. So later on, they will have hyperphagia and obesity, but in the infancy period, they will have feeding difficulties and hypoglycemia. The other one, Russell-Silver syndrome, also will have some feeding difficulties. They will also have some hypoglycemia during the infancy period. Okay, so that much about the perinatal period. Okay, and usually, yeah, the AGA, SGA we've already discussed. So you can go to the next slide.
Developmental history. Child is developmentally normal, attending kindergarten, average studies, immunized up to age according to IAP.
Okay, so if there is developmental delay with short stature, what are the common causes you will think of?
Any syndromes, ma'am?
Yeah, syndromic short stature. Okay.
And hypopituitarism can also have
hypopituitarism. They will not have developmental delay unless you don't pick up the hypothyroidism early on. then they will have developmental delay. If you pick up the hypothyroidism early on, then you will not have developmental delay. Main thing, if you use a TSH screen, you can miss a central hypothyroidism. But if you do a free T4 and TSH, definitely we can pick up the hypothyroidism on time. And if we treat, they will not have developmental delay. Okay. So mainly it is all syndromic short stature. Many of the syndromes can have developmental delay. Okay. So we can go to the next one.
In dietary history, the child was breastfed till 5 months of age and weaning was started at 5 months of age. And calorie, she's getting around 800 kilocalories per day, but the expected kilocalories was 1050 per day. It's a deficit of 250 kilocalories per day. And protein, she's getting 7 grams per day with a deficit of 4 grams per day. Expected was 11 grams per day.
Okay.
Family history. Child was first born to third degree consanguineous parents. There was no history of significant illness in the family, no history of significant illness in the family, no history of short stature or delayed puberty in the family. And second sibling, he's thriving well. He is attaining normal height with the normal height velocity. No history of disharmony in the family.
Okay. So why did you ask all this? So can you tell me the importance of no history of significant illness in the family?
Any syndromes, whether the genetic causes of short stature, already there's any other persons in the family with the developmental delay, short stature, anything? Anyone?
Okay,
And they,
actually, what is more common is we see parents to be short and we see the child to be short. So we cannot just label as familial short stature. Sometimes there can be some diseases, genetic diseases running in the family, which we can miss off. Okay. So we have to ask them whether they had any problems, any other health issues they had, or their spine, they had any spine problems. So these are for like, suppose, they had early, suppose the father had early puberty and then ended up short stature, then the child is also having early puberty, then child also will end up short stature. So this is familial testotoxicosis. So we have to see whether they had any other diseases which is running in the family and causing familial shorts. I mean, in family, everybody is short because of the disease running in the family. So that is why you have to ask for significant family, history of illness in the family members. Okay, and familial short stature, you have asked no history of short stature in the family. And puberty, you have asked for constitutional delay and growth in puberty. Okay, it is for that. Apart from that, no history of disharmony in the family for what?
So any psychosocial disturbances in the family?
Psychosocial deprivation also can cause short stature. And no history of delayed shaving in the family?
To ask about the delayed puberty.
Yeah, usually the dad will say that he was very short in the middle school period, and then all his friends were growing taller than him, but he remained short. And then he had a later growth spurt and later onset of mustache and beard also, they will tell. They will classically give you a late growth with a late onset of mustache and beard and hence later shaving. Okay, so we'll go to the next slide.
And socioeconomic history, that was a nuclear family living. A father is a doctor and mother is a software engineer, belong to upper class to modified chromosomal scale. Summary, here is a 6-year, 10-month-old school-going girl with who was developmentally normal and first born to third degree consanguineous parents with short stature, noticed in birth, with delayed dentition and with no other future for significant chronic systemic illness.
Okay. Okay, so we'll continue with the examination. Hemchand sir will carry on.
Yeah, so I think at the end of history, Dr. Sandeep has arrived at a child who has short stature, significant short stature, and born to third degree consanguineous parents. The child also has delayed dentition, and he does not have any significant evidence of a developmental issue or any chronic systemic disorder. So in this background, he is considering what are the diseases that you would like to consider in your mind.
I would like to consider syndromic causes and endocrine abnormalities in the child.
Yeah, okay. Syndromic despite normal development. Okay, so endocrine disorders you're having in mind, but the early age of onset is since birth as per your history. let us see. These are probable differentials. Maybe the physical examination, see whether it gives you some clue. Right. Can we go on?
Yes, sir. On examination, child is alert and interested in the surroundings. No pallor, cyanosis, clubbing, or pedal edema. Her vital signs were stable, and BP is according to the BP is in the 50th centile.
Very good. Can you? What clues do vital signs give you in a short child?
If the child is having hypertension, means then we have to think about systemic illnesses like CKD, chronic kidney
Excellent.
disease,
Okay. Anything else?
and Cushing's with the hypertension.
Excellent. Anything else?
Bradycardia and hypothyroidism.
Very good, Mitra. Bradycardia and hypothyroidism. Anything else, Mitra? Intracranial tension, raised intracranial tension because of intracranial tumors and GHT. What would be the vital signs?
Hypertension,
Very
bradycardia.
good. Very good. Very good. And Dr. Mitra, can you explain what is the meaning of this 50th percentile? What he has written?
50th percentile means the child is 50% of the children are like below. The child is below the other rest of the 50% of the population.
Yeah, I mean, no, in the context of this blood pressure.
Okay.
So probably I think one would first have to take the height, look up the percentiles, see where the child's height percentile is. For that height percentile, how does the systolic blood pressure match, whether it is at the 95th percentile, 90th percentile, 50th percentile or lower. And as similarly, correspondingly, you have to do it for the diastolic blood pressure also. So I think blood pressure interpretation comes in the perspective of the height percentile. And sir has also mentioned, very important, that you should also take a lower limb blood pressure if you're in especially a short statured child, because in case you're, especially this is a girl child, if you're thinking in terms of Turner syndrome, you will have to think in terms of associated cardiac problems like coarctation of aorta. To pick up coarctation of aorta, you will have to take a lower limb blood pressure also, isn't it?
Yes, sir.
Okay, right. Go on.
Anthropometry. Weight of the child is 11 kg, but the expected weight according to the 50th centile is 20 kg, and height of the child is 82 centimeter. Expected height is 113 centimeter.
Very good. Can you explain to me? Can you recite the steps of height measurement in this child that you performed?
We have to ask the child to stand in the stadiometer with the bare foot facing straight. There should be three contact points in the stadiometer at least. Back of the head and back of the shoulder and back of and buttocks and back of the heel should be in contact with the stadiometer. With the Frankfurt plane perpendicular parallel to the base of the stadiometer, we have to measure the nearest 0.1 centimeter.
Very good. Okay, so that's how you would take height. And if the child has any braid, will you remove it? Isn't it?
We have to remove.
Very good. Okay. If the child has any braid or thing, you should remove it before measurement of the height. And where should your eyes be placed while measurement of height?
Eyes should be looking straight.
Very good. And your eyes, the examiner's eyes?
Should be.
You should be looking at the level of the
boards.
Yes, very good. Very good. Okay. And what about weight? How did you measure weight for this child?
Weight, again, if the child is more than 2 years old, we can ask the child to stand in the weighing machine with the bare foot, slightly foot apart, and then ask the child to. We have to ask the child to look straight, the minimal clothing as possible.
Right. Very good. And measure it to the nearest how many grams?
Nearest 0.1. Nearest 0.1 gram.
Very good. 100 grams. Okay. And how would you at below what age would you measure length?
Below 2 years, we have to measure the length, sir. How
would you measure length? Can you recite the steps?
there will be a need of 2 persons to measure the length.
Excellent.
Child should be placed in the infantometer. Head should be
Okay.
placed in the fixed end of the infantometer.
Very good.
And with the, we have to fix the head of the child at the one end, and one person should stand at the foot end. They have to fix the knee, and they have to move the foot plate of the infantometer, and they have to stretch the leg, and they have to measure the nearest 0.1 centimeter.
Excellent. Very good. So, and below 2 years, you would have to measure the length of the child. And also the ankle should be perpendicular, isn't it?
Sir.
Okay. And if a child can stand, suppose you have a 1.5-year-old child who can stand, would you measure the height or the length?
We can measure the height, but
Yeah.
we have to increase. We have to add a 0.7 centimeter in the height.
Even if the child can stand, it would always be preferable to measure the length, because if you see the WHO charts, they have been constructed by using the length in the initial 2 years of life, isn't it?
Okay. Yes, sir.
Next one, next slide.
The anthropometry and upper segment lower segment ratio is 1.2:1. Arm span is 84 centimeter. And height of
Just
the
a second. Mitra, what do you mean by upper segment lower segment ratio? Can you explain how should it be taken?
So upper segment is from vertex to pubic symphysis, sir.
Okay.
And lower segment is from upper border of pubic symphysis to heel. So generally we take the total height of the child, and from that height we should minus the lower segment.
Very good.
So that by minusing the lower segment, we will get the upper segment. So we have to divide upper segment by lower segment.
Very good. So I think sir has also added a point that in case you are thinking in terms of syndromic short stature, you should also measure head circumference. But this being a 6-year-old child and developmentally normal, probably if it's a younger child with the developmental issue, probably head circumference also is a very important value along with height and weight. So what are the normal? Very good, Dr. Mitra. Can you tell me the normal upper segment, lower segment ratios in different ages?
Birth, it is 1.7:1. So around 5 years, it will be like 1.3:1. And around 7 to 8 years, both upper segment and lower segment will equalize. That is 1:1.
Yeah, so it will be 1.7. It will serially come down. By around 7 years, it becomes 1:1. So any alternative of for upper segment, lower segment ratio? Sitting height, isn't it? Sitting height
yes.
can be taken. Right. Very good, Mitra. Yes, Dr. Sandeep, please proceed.
Arm span is 84 centimeter. Father height is 74 centimeter. Mother height is 168 centimeter. Mid-parental height is 164.5 centimeter.
Excellent. How did you calculate the mid-parental height?
Father's height plus mother's height minus 13 centimeter in girls or plus 13 centimeter in boys divided by 2.
Excellent. Very basic. Very rightly you have said. So, and if it were boys, you would add. Because it's a girl child, you have subtracted, isn't it? Yes. And how does the 13 centimeter arrive at? Because it is based on the European data, that there is a 13 centimeter difference between the average man's height and the woman's height in adulthood. So, what is the target height range for this particular child?
This is between 158.5 centimeter to 170 centimeter.
How did you get that target height range?
We have to add 6 centimeter and minus 6 centimeter, and we have to make a range.
Very good, very good. So previously we used to think of it as 8.5 centimeters. Currently it is lowered to 6 centimeters as the target range. Okay, very good. Next slide.
And this is the growth chart.
Very good.
We can see that. The child is 6 to 10 month old child with the weight of 11 kg, which is below the 3rd centile, and her height is around 82 centimeter, which is well below the 3rd centile. In comparing to the height and weight, height is more affected because it is. It has fallen more than the weight. And
Excellent, excellent, Dr. Sandeep. Very beautifully, rightly, perfectly plotted. So can you tell me how did you plot the height? Where did you plot and why? At the point of intersection of the height on the y-axis and the chronological age on the x-axis, isn't it? How did you plot it? What did you use? Did you use a dot or a cross, or what did you use to plot it?
We have to use only, we have to make only dot. We should not use any other symbols. Only dot simply, we should not encircle anything.
Very good. How did you plot weight?
Weight again, with the x-axis being the chronological age and y-axis being the kg of the child, we have to intersect and we have to make a dot.
Excellent.
And,
very simple, basic. So, you have in this chart itself, you have calculated the height, age, and weight age. So this is a 6-year, 10 months old child. So what is the height age of this child?
Height age of this child is around 1.7 year.
Very good.
And weight age of the child is about 2 years.
Excellent. So, Dr. Mitra, can you tell me what is the meaning of this height age? Dr. Mitra?
Yes, sir. Yes, sir.
What is the meaning of this height age of 1.67 years?
So usually the 50% of the population of the same age and sex should be in that height.
Yeah, correct. So the child, even though she is chronologically aged 6 years, 10 months, has the height corresponding to that of a 1 year, 7-month-old child. She has the average height of a 1 year, 7-month-old child, isn't it? Even though this child is chronologically aged 6 years, 10 months, this child has an average weight of a 2-year-old child, isn't it? The weight and the height corresponds to that particular age. That is what is the concept of this height age and weight age, isn't it? Very good. So, Dr. Sandeep, can you also show me how you have plotted the target height?
I have calculated the target height already. With the range of 158.5 to 170 centimeter, we have to take the 158.5 centimeter as the third centile, and then 170 centimeter is the 97th centile for the child.
For the family. For the family. Excellent.
Yes.
Okay. So that will be the range for the family. So he is marking it as a horizontal line at the target height, and he's marking it as 2 arrows above and below at 18 years of age. This is how perfectly a growth chart should be plotted. So because we are sitting in the growth chart itself, can you tell me how did you plot the bone age? Although we are going to come back to it, this child had a bone age of 1 year. So where have you plotted the bone age and how did you plot it?
In the 1 year of age, we have to see again, we have to mark the height of the child. 1 year, 82 centimeter. So we have to mark, we have to differentiate between height age of the child and with the bone age. So we have to differentiate with the other symbol, triangle. Triangle is the one we can use for the bone age.
Very good. So bone age is marked at the point of intersection of the bone age on the x-axis and height on the y-axis. Either a triangle, as Dr. Sandeep has done, or a cross. Both are acceptable. So when you mark the height of for the chronological age, you use a dot. When you mark the bone age for the height, you will use a triangle or a cross, and you join it by a dotted line. So this child's chronological age is 6 years, 10 months. What is the weight age, Dr. Sandeep?
Weight age is 2 years.
So what is the height age?
Height age is 1.7 years.
And what's the bone age?
Bone age is 1 year.
Very good. So beautifully he has got the diagnosis comes out in this particular beautiful plotting. At the chronological age of 6 years and 10 months, the child has a weight only of a 2-year-old child, height only of a 1.5-year-old child, and a skeletal maturity of just a 1-year-old child. I think the diagnosis sparks out in this simple growth chart itself. So because you're sitting in the growth chart, can you tell me, using a growth chart, what is the definition of short stature on this growth chart?
Any child with height less than -3, any child with a height less than 3rd centile.
Yes, so you can see the line, which is the 3rd percentile line, and the child's height, Dr. Sandeep has plotted, is way below the 3rd percentile line. So this is the this child has short stature. So short stature is diagnosed based on this. Can you go to the BMI chart?
Yes.
Very good. So this child, what is the BMI and where have you plotted it?
As this child's BMI is about 16.5 per meter square. Because weight and height both are equally affected, the child's BMI is falling within the normal
range or just touching the overweight range, isn't it? So what is the definition of overweight in a child above 5 years, Dr. Sandeep?
In the child above 5 years, the BMI is crossing the 23rd adult equivalent. We can consider that as overweight.
Excellent. And what's the definition of obesity?
And any child with BMI more than 27th adult equivalent will be considered as.
Okay. So standard definition. What is the definition of short stature, severe stunting, overweight, obesity in a child above 5 years? Dr. Sandeep has very beautifully told. Remember, in this whole set of 4 definitions, there is no definition for weight below the 3rd percentile because IAP does not want weight to be interpreted without the interpretation of the height. Just for completion's sake, Dr. Sandeep, can you tell what is the definition of short stature or stunting, overweight and obesity in a child less than 5 years?
If child having a less than 3 standard deviation, height of the child less than 3 standard deviation, it will be considered as severe stunting. Less than 2 standard deviation can be considered as stunting. And more than 2 standard deviation of the weight is considered as overweight, and more than 3 standard deviation can be considered as obesity.
Very good. BMI or weight for height above +2 SDs and above +3 SDs is overweight and obesity. What is underweight?
And again, the weight below the -2 standard deviation, weight for age -2 standard deviation will be considered as underweight.
Excellent. So very commonly made mistake. Underweight is weight for age. Underweight is weight for age. Overweight and obesity is weight for height. Is it clear? So terminologies, you should use what is recommended by the World Health Organization for children below 5 years and what is recommended by the Indian Academy of Pediatrics above 5 years of age. Very beautifully. So you find that this child has a normal or a slightly elevated BMI. So this child has stunting, short stature. Would you call this proportionate stunting or disproportionate stunting, Dr. Sandeep?
I would call this as proportionate stunting, sir.
Very good. A preserved weight gives you important clues to the diagnosis of the underlying cause for short stature. Very good. Right. So many information, so much of wealth of information Dr. Sandeep has provided by plotting this growth chart properly. So BMI is plotted at the point of intersection of the age, chronological age on the x-axis and the BMI measurement on the y-axis, isn't it? That is how he has plotted the BMI. So can you just sum up? Can you minimize this this slide and tell me what are the important lessons this growth chart teaches you?
This growth chart, we can see the height of the child is more affected than the weight, and height age is more delayed than the weight age, and then bone age is more delayed than the both height age and weight age.
Very good. The child is stunted. The child is having a relatively preserved weight because the BMI is normal. The child, it's a proportionate stunting. Child is significantly short for the population. Child is significantly short for the family. Child has a very much delayed skeletal maturity. The child has affection of height more than weight. So 7 important learning lessons this growth chart plotting of Dr. Sandeep has provided us. Next slide.
Anthropometry.
Very good.
Weight falls below the 3rd centile, less than 3rd centile. The Z-score is -4 standard deviation, underweight, and the height falls below the below the 3rd centile. Z-score is -6 standard deviation. BMI is falling in the 0.77 standard deviation. Target height is between 50 to 97 centile.
Excellent. So Dr. Mitra, can you tell when Dr. Sandeep says that this child's BMI is at the a 50th centile. What does he mean? Can you tell me what is the meaning of the percentile? What is the meaning of that? Dr. Mitra?
Meaning of percentile, sir?
No, suppose he says that the BMI is at the 50th percentile. What does that mean to a lay person? Suppose I am the mother of this child. What do you want to convey to me when he says that the BMI is at the 50th percentile?
He's like in midway.
Excellent, excellent. So
Midway of the
if you have 100 children who are born along with my daughter, my child ranks exactly at the 50th position. 50% of the Indian children born along with my daughter has BMI less than that. 50% of the children have BMI above that. So my child has an average BMI. Suppose he says that my child has BMI on the 3rd percentile. What does he try to mean? What does he mean by that?
97 persons are like above the
above the have BMI more than my child, and 3% have
below.
Excellent. Suppose he says that my child's BMI is on the 97th percentile. What does that mean? Dr. Mitra?
Yes, sir. Yes.
So what does it mean when he says that my child's BMI is at the 97th percentile?
He is more 97 people are like behind the children.
Excellent. Only 3% of the children have BMI more than my child, but 97% of the children have BMI less than my child. They are very thin compared to my child, isn't it? So it is kind of a ranking system. But look at the Z-score. He says that my child's height Z-score is -6 SDs. So to a lay person, can you explain to me what is the meaning of this word -6 SD?
Standard deviation is,
Excellent. So
from the mean population, how much they are deviated.
Yes, it tells you, number one, how much they are deviated. The number tells you how much they are away. So within 2 standard deviations, you would expect the child generally to have a normal anthropometric measure. Anything beyond 2 would always worry you. So 6 is significantly away. My child has a height that is significantly discrepant from the population. And what does that sign tell you? Minus. What does that tell you?
Negative.
Negative. Excellent. So my child has a height that is 6 standard deviations away from the population. So my child is very much away from what would be the median for the population. She is very much away, and she's away in the negative direction. So I have to do something to push my child forward. Suppose this child's height were +6 SDs. What does that tell you?
Obese.
Height.
A tall stature.
My child has overgrown. She's very tall. She's 6 standard deviations away from what would be the average for this age. So what should I do? I should do something to promote her growth or stop her growth.
We have to stop. We have to find out the cause.
You have to do something to stop her growth. So percentiles and Z-score nearly tell you the same message, but it tells you percentiles tell you in a form of a ranking system. Z-score tell you in the perspective of the standard deviation and the direction the child is performing in comparison to other children. Okay, Dr. Mitra, Madam gave a definition of the percentiles of the definition of short stature based on the perspective of the target height percentile. You look at this chart, what Dr. Sandeep has said. He says that the target height is between the 50, is close to the 90th percentile, and he says that the child's height is below the 3rd centile. So is this child short for the family? Is this child short for the family? Yes, definitely this child is short for the family. Based on the genetic potential, the child's height should have been at the 90th percentile. So when the child's target height is at the 90th percentile, even if the child's height is at the 10th percentile, so child is 2 percentile lines away from the target height. Are you able to understand? In between, there is a 75th, there is a 50th, and there is a 25th. My child's height is at the 10th percentile, but my target height is at the 90th percentile. I am more than 2 percentile lines away from the family's target height. So my child is short or not?
Yes, sir.
So we're able to understand the perspective, the 2 percentile lines difference between the target height and the individual child's height percentile makes you make a diagnosis of short stature. Is it clear?
Yes, sir.
So you can diagnose short stature based on the performance of the child in the perspective of the population, like that growth chart. Number two, you can make a diagnosis of short stature in the perspective of the family height percentile, like this particular table. That is what is the target height centile? What is the child centile? That is a second way of making a diagnosis of short stature. And the third way, what is the way of making a diagnosis of short stature, Dr. Sandeep? Growth velocity. Please do it in the next slide.
This is the velocity chart of the child. And to calculate the height velocity, we have to take a formula and we have to calculate the height velocity. We have to take height in the two time period. We have to make a difference between the two time period height and into 12 divided by difference between the time 2 and time 1 in months. So that will give the height velocity per year.
Very good.
This child height velocity, this child is 6 years 10 months old. It is around 1.8 centimeter. It is well below the third centile for the height velocity chart.
Excellent. Excellent. So height velocity is calculated as the height in between two time periods, and then you have to extrapolate it to 1 year, and you have to plot it at the point in between the two time periods. So any height velocity, what is the percentile cutoff for height velocity?
25th centile.
Excellent. Excellent, Dr. Mitra. So now that we have seen the three definitions for short stature, Dr. Mitra, can you sum up the three definition points for short stature?
Yes, sir. So first definition is height less than third centile or 2 standard deviation. The other one is a growth velocity of less than 27th centile.
25th.
So 25th centile. And third one, we can mid-parental height. Can we do it with
yeah, so two percentile lines below the target height percentile, isn't it? So this way you make a diagnosis of short stature. Very good. Right. So much of wealth of information he has provided from Anthropometric. So Madam says there are certain special conditions for which growth charts are available. Can you just sum up some of them, Dr. Mitra?
Yes, so Down syndrome, Turner syndrome, and we have a Prader-Willi syndrome, and achondroplasia. Also, we have a separate growth chart, specific growth charts.
Yeah, and hypochondroplasia and Russell-Silver syndrome. Okay. So these are the common conditions for which special growth charts are available for plotting of growth. Right. What are the advantage of plotting the growth in those charts? Because you can pick up if they are a candidate for growth promoting therapy, it will help you to assess the response. And also if they have comorbidities, you can pick it up, isn't it? Very good. So I think all the major points you have covered it very well. Go to the next slide, Dr. Sandeep.
Interpretation, and we can see the child's height age is more affected than the weight age, than that of the chronological age. This is the interpretation from the growth chart.
Very good. Go on. So you have also already plotted the bone age also, and bone age is also 1 year. So to a lay person, can you just go back to the previous slide? Yeah. So this child is chronologically aged 6 years, 10 months. So chronological age more than weight age, more than height age, more than bone age. So what do you, as a lay person, can you explain to me what this means?
So when in your child the weight age is more affected. The child is not growing up to the age when comparing to the chronological age, and the height is more affected than the weight, and bone age is much more delayed than chronological age. So she's not growing well, and there is some major cause will be there. We have to put the cause for the
excellent. Okay, so this child, I would say your child, your mother, is 6 years 10 months, has the weight of just a 2-year-old child, has the height of only a 1.5-year-old child, but has the potential to grow of that of a 1-year-old child. Bone age tells you the potential for growth. So we have to do something to immediately find out the cause and try to rectify it so that she reaches the chronological age, weightage, and height age of a 6 years and 10 months old child. So that would be the concept of this chronological age, height age, weightage, bone age business. Suppose you have the reverse. You have a chronological age more than height age, more than weightage. What would you think?
In the precocious puberty, height will advance.
No, chronological age more than height age, more than weightage. Child is still short, undergrowing, poorly growing.
Malnutrition.
Excellent, Dr. Mitra. Malnutrition. Both weight and height are affected, but your weight is affected more than the height. Chronological age more than height age, more than weight age. Weight is the lowest, so you think she is thinking in terms of malnutrition. If it were precocious puberty, height age will go ahead of the chronological age. You will have height age more than chronological age, more than weight age, isn't it? Height is pushed forward. Something is pushing the height forward. Either it may be because of the genes or it may be because of the sex hormones. Suppose you have weightage more than height age, more than chronological age. Dr. Mitra, what would you think? Weight is forward, height is forward, weight is much forward. What would you think?
So I'm not able to get you, sir.
Weightage more than height age, more than chronological age.
Here weight is more, sir. So I would think of like more weight gain, obesity.
Excellent. So she is thinking in terms of obesity. Whenever you have a child who is 6-year-old, 10 months, has the weight of a 15-year-old child, has the height of a 10-year-old child. Something is pushing this child's growth forward. Look for it, control it. That is nutritional obesity. Right. Very beautifully discussed, and by anthropometry itself, you have probably arrived at a beautiful underlying probable cause. Yes, go ahead, Dr. Sandeep.
Head to toe examination. The child was found to have frontal bossing with prominent eyeballs and high-pitched voice, with the crowding of teeth. There was no midline defects. Eyes, nose, and ears are normal. Fundus examination revealed no papilledema. Oral cavity is normal, no cleft palate or cleft lip. No webbing of neck and shape chest is normal. No goiter. And there was no skeletal.
Just go back. Yeah, Dr. Mitra, can you tell me what are the phenotypic features of GST quickly one should look for?
In case of growth hormone deficiency, starting from face, the face will be immature and they'll have frontal bossing. And in the face, we can also have this midfacial defects, and they'll have these crowded teeth. So when we come to trunk, they will have central obesity, and their hands and feet will be small. So these are main features.
Very good. You can also look for single central incisor. You can also look for cleft palate, cleft lip, isn't it? Yes. Quickly, can you rattle out the phenotypic features of GHD? Turner syndrome.
So in case of Turner's, so the female child will have this low posterior hairline, sir, and there'll be webbing of neck, shield-like chest, and we have to look for carrying angle to look for the cubitus valve.
Excellent. And also palpable of the femoral pulses. Very good. Can you quickly tell me the clues from the eyes you can look for? He has already mentioned many.
Generally, so this
in a short child.
In a short child, starting from outside, we can look for icterus in case of any chronic liver disease, and cataract in rubella. We can look for, in newborn children, we can look for cataract, and papilledema in case of the craniopharyngioma. In such cases, there will be papilledema due to high intracranial pressure.
Very good. And of course, hypertensive retinopathy, etc. Right, he has said no goiter. So how would you look for a goiter?
Goiter, we have to, if you're not able to, if it is not visible, we have to stand behind the patient and we ask the patient to flex the neck down, sir. And we have to palpate with our fingers other than the thumb. So the thumb should be positioned posteriorly, I think.
Excellent. And the examination of goiter is never complete without looking for lymph nodes, movement with deglutition, and movement with protrusion of tongue. Isn't it? Right. Next slide.
There was no skeletal anomalies or no hyposcoliosis, no obesity. Forearms, arms, and hands are normal. Skin is normal. There was no neurocutaneous markers, hair and nail as normal, no symmetry, no asymmetry of the body, and the external genitalia, SMR is pre-pubertal stage 1.
Excellent. Very good. So you have made a head-to-toe examination, right? Systemic examination.
Systemic examination is normal. There are no significant findings noted in the systemic examination.
Very good, very good. So can you just sum up what are the key points?
Here is a 6-year, 10-month-old school-going child with who was first born to 3rd-degree consanguineous parents with short stature, notice in birth, delayed dentition, and no significant other illness. On examination, we found phenotypic features of hypopituitarism like frontal pausing, crowded teeth, and high-pitched voice. Child is proportionately short with severe stunting, with the height more affected than the weight, along with very low height velocity, with normal genitalia, no evidence of systemic illness.
Very good, very good. So before we forget, the child's school performance, peer interaction, all that was good?
Yes, sir.
I think probably sir wants us to include that also in the discussion, because that will give a perspective about the psychosocial aspect of short stature, which this child with short stature is going to encounter. So based on this history and physical examination, what would you like to offer as a differential diagnosis?
Child is having proportionate pathological short stature, and I would like to consider isolated first growth hormone deficiency as the first thing. Then I would like to consider hypopituitarism.
Very good, very good. Right. Very nicely you have summed up just as a likely cause. Probably, as sir has mentioned, treatment history is to include, because you know this diagnosis and they are giving you a clue, that will also probably add to for you to zero in into the probable diagnosis in the cause. Before we go on to the further evaluation, a quick question, Dr. Mitra, what is what do you mean by BMI lookup tool? Because in this BMI lookup tool, Dr. Sandeep. See, it's a new definition of to identify overweight, obesity, and undernutrition based on just weight and height without having the need to calculate BMI. So it is useful in children above 8 years of age. So that is the BMI lookup tool. Very good. Okay. So even in the phenotypic features, you can also include any phenotypic features of Prader-Willi syndrome as well in short stature. So based on your history, physical examination, you are arriving at a probable endocrine cause for short stature. Okay. Now over to Dr. Soundaram for evaluation.
Yes, Sandeep, we can proceed with the investigations.
I would like to do a baseline investigation for the child to rule out any systemic illness. I would like to order for CBC with a peripheral smear to rule out chronic malnutrition with anemia, other infections, immune deficiencies. Okay. RFT to rule out renal tubular acidosis and CKD. Okay. LFT to rule out chronic liver disease. And any child with a short stature, first we have to do a thyroid profile because it is the most common cause for short stature. Hypothyroidism should be ruled out, and urine routine to nephrotic syndrome when the child will receive steroids for long-term steroids. So we have to do urine routine. Then bone age.
Urine routine we don't do for nephrotic syndrome actually. Urine routine basically to see the pH for RTA, if there is any proteinuria, glucosuria. For RTA, we basically do the urine routine. Apart from that, some children can have recurrent UTI, so chronic pyelonephritis they can have, which is leading to CKD and short stature. No? So for that only we do urine routine, mainly for RTA. Okay. So next, bone age.
Bone age to know how much delay is in the actually the child is. We have. Okay.
So this thyroid profile, can you tell me how will you differentiate a primary hypothyroidism from a secondary hypothyroidism, like central? So how will the free T4 be in primary hypothyroidism, and how will the free T4 and TSH be in a central hypothyroidism?
In the primary hypothyroidism, free T4 will be low, but the TSH will be high because due to the feedback. The secondary hypothyroidism, both free T4 and TSH will be low because there is a low production from the pituitary itself.
Yeah, so mostly it is very easy to diagnose if the TSH and free T4 are low in central hypothyroidism. But however, sometimes you will get a normal TSH or a slightly elevated TSH also, which is inappropriate for the very low free T4. Okay, so in a central hypothyroidism, the TSH can be low, normal, or inappropriately slightly elevated. Okay, suppose the free T4 is just 0.4, 0.5 like that, but you are seeing a TSH of 6 or 7, then we say it is inappropriately elevated for the free T4. So basically, primary hypothyroidism is very easy to diagnose, very high TSH with a very low free T4. And central hypothyroidism, you will have a low free T4 with mostly normal TSH is what we see. Sometimes it can be a low TSH or an inappropriately elevated, slightly elevated TSH, okay? And bone age, how will you interpret, and what is the X-ray you will take for bone age interpretation?
For bone age, we would like to consider to order non-dominant hand wrist X-ray.
Okay.
We can use Grulich pile atlas to compare with the. We can assess bone age.
Okay, so bone age, actually you have to take the left hand with wrist. Okay, so left hand with wrist AP view. So you have to be very clear in what X-ray you want. Left hand with wrist and AP view you should take. And basically the Grulich pile atlas has only images of the left hand with wrist to compare with. So if they take the wrong hand, it's very difficult to interpret for you. And what are the other things you know to interpret the bone age apart from the Grulich and pile atlas?
Tanner-Whitehouse method.
Yeah, Tanner-Whitehouse method. So there is the Tanner-Whitehouse 2 and Tanner-Whitehouse 3. Okay, these are more accurate than the Grulich and pile atlas. You will get it more narrow bone age period, okay, rather than getting a wider bone age period, okay. And these two are the manual methods where we physicians have to interpret the X-ray. Do you know of any automated method where you can get the bone age from a software?
Bone expert.
Yeah, bone expert you can use. Yeah, that's correct. Okay, so the other investigations, what else you want to do after ruling out a systemic disease?
And we have to say we have to proceed for ruling out the syndromic causes and endocrine causes in the next layer of investigation and malabsorption, immunoglobulin profile to rule out immune deficiency, and then IgA and TTG levels to rule out celiac disease, and karyotyping to rule out syndromic features like Turner syndrome, and growth hormone initial step of assessment with the growth hormone and IGF-1 levels, random growth hormone and IGF-1 levels. Then followed by, if the IGF-1 is low, then we can do a growth hormone stimulation test and other hormones. Then imaging needed.
Okay. So actually this TTG levels, basically for what disease are you doing this TTG levels?
Celiac.
Okay, so for celiac disease, you're doing the workup. So celiac disease, can it present only with short stature initially, or surely there will be GI symptoms?
Initially, they'll have GI symptoms.
Actually, it can be the reverse also. They can have short stature from the very beginning, and the GI symptoms may manifest little later also. Okay, so when constipation and short stature is there, definitely you will think of celiac disease, but sometimes the short stature can precede the onset of the GI symptoms as well. And why you want to do the IgA levels?
Inherent IgA deficiency will cause.
Okay, so whenever you're doing this anti-TTG, you have to do both the IgG and the IgA anti-TTG. And we do the IgG also because sometimes this IgA deficiency can cause a lower TTG levels, which we think is normal. That's why we do the IgA and IgG TTG levels. And we do the serum IgA to see if there is any IgA deficiency, immunoglobulin A deficiency. Okay, so that is clear. The next thing, usually we don't do a random growth hormone levels. Whenever we want to do a growth hormone, we typically go ahead and do the growth hormone stimulation test. Okay, so the random growth hormone levels doesn't carry much significance. And IGF-1, can you tell me some drawback of testing IGF-1 levels in children? Basically, what is IGF-1?
growth factor 1.
Insulin like growth factor 1, yes. So, like, why do you test for the IGF-1?
Because this is the active form of growth hormone.
Yeah, so once the growth hormone acts on the receptor, it is going to generate the IGF-1, which leads to the growth of the cells. Okay, so what is the drawback of testing IGF-1, especially under 5 years of age?
Any systemic illness can easily affect the production of
So
IGF-1.
chronic liver disease, chronic kidney disease also can have IGF-1 low. Okay, apart from that, suppose the child doesn't have a CKD or a CLD. Even pure malnutrition itself can cause low IGF-1 levels. Okay, so in an undernourished child, if you do IGF-1 levels, it may come low. Seeing that, we should not think child is growth hormone deficient. Okay, so the main thing in under 5 years, IGF-1 can be low in malnutrition itself. Okay, that is one thing you have to remember. Okay, so other hormone levels. Okay, we'll go to the next one.
Actual investigation of this child's CBC, RFT, LFT, and ESR was normal. ALP is normal with normal calcium and vitamin D levels. Her free T4 level is 1.26 with a normal TSH 2.6. Urine routine is normal. Bone age is 1 year. Here also.
Have you finished with this now? Okay, continue. Yeah.
Bone age is much more delayed in comparing to the other anthropometric parameters. So we would like to consider endocrine etiology. So we have to proceed to the next line of investigations.
Okay. Suppose I tell you the child has hypocalcemia with hyperphosphatemia and short stature, then what will you think of? Hypocalcemia, hyperphosphatemia with a normal ALP and short stature.
CKD, ma'am.
Okay, CKD also can have like that, yes.
Pseudo hypoparathyroidism.
Yeah, pseudo hypoparathyroidism, yes. So pseudo hypoparathyroidism, they will be short and stout. They will have a stocky build, we will call. Okay, so and they can be mildly developmental. IQ may be slightly lesser for these children. So that is one thing you have to remember. Okay, okay. So we'll go to the next slide.
Second layer of investigation, her karyotyping is normal, XX. IGF-1 level is less than 15, which is very low. Growth hormone levels are very high, 30.4 nanogram per ml, and serum cortisol levels within limits.
Okay, so can you tell me about the growth hormone stimulation testing? What are the agents medicines you will use for stimulating the growth hormone levels in the body, and the cutoffs we use to define growth hormone deficiency?
Glucagon and
Yeah, Dr. Mitra.
clonidine can be used, ma'am.
Okay, glucagon and clonidine are the most commonly used agents. Apart from
commonly
that,
used.
Yeah.
Arginine, L-Dopa.
Okay.
And even like previously they were using insulin in the earlier time.
Okay. And GHRH also we can use. Okay. So what are the most common side effects you have to watch for when you're doing a clonidine stimulation test? So what we routinely do is a clonidine stimulation test. So you would have seen some patients undergoing that test. So what did you monitor during the growth hormone stimulation testing?
We'll monitor for the BP, ma'am. Clonidine can cause hypotension.
Yes. Okay, so this clonidine stimulation test, mostly the child will get drowsy and they can have hypotension. Suppose hypotension develops, so what are you supposed to do?
We have to start an IV fluid.
Yeah, NS bolus is what you have to give. Okay, because this is going to be a very short-acting drug, so the effect will wean off within a few hours itself. Within less than 6 hours, it will wean off. So temporarily, you have to manage with fluids. So basically, we give a NS bolus. With the bolus itself, the BP will settle. And usually, once the procedure is over, once the child eats and all, they will be better. Okay, so will you keep for observation after the stimulation test is over? How many samples you will take for the clonidine stimulation test?
4 samples, ma'am.
Okay.
Usually fasting we will take, ma'am. After that,
0,
30, 60 minutes and 90 minutes.
Okay. So you mean that only 0 minute will be a fasting sample or
previous, ma'am? Even before 0 minute will be First, we will take it fasting.
Okay. So like when will you allow breakfast for this child who is undergoing a growth hormone stimulation test? Can you give it after the 0-minute sample?
Only after the
Finish,
end of the sample.
Correct. After the last sample you have taken, only then you can give the you can give the breakfast. Okay. So wait till you collect the 90-minute sample. After the 90-minute sample, you can allow breakfast. And usually we keep the children under observation for at least 2 hours to monitor for the hypotension. Once we feel that the child's BP is normal, the child is alert, then only we send them home. Okay. So for the glucagon stimulation test, like what is the common side effects you have to watch for?
Hypoglycemia.
Yeah, hypoglycemia, rebound hypoglycemia. Then actually it's a drug you use for treatment for hypoglycemia, no? So it can push up the hyperglycemia followed by rebound hypoglycemia can happen. Okay, so rebound hypoglycemia you will look for, and child can have vomiting tendency, nausea and vomiting. Okay, so these are the things you will look for when you're doing a glucagon stimulation test. And usually the glucagon stimulation test requires an extended period of testing. So until 180 minutes, we will take samples for this child. Okay, usually the clonidine is quicker. 90 minutes is the last sample. However, for the glucagon stimulation test, up to 180 minutes, we will take the samples. Okay. Okay, and the serum cortisol, we have to take 8 a.m. fasting. All hormonal tests, basically you have to do fasting between 7 to 9 a.m. Okay, okay. We'll go to the next slide.
Growth hormone stimulation.
And 1 minute, the cortisol, usually if it is less than 5, we take it as low. Okay, a baseline cortisol less than 5, we consider it low. And at the time of hypoglycemia, you have the cutoff of 18. Okay. So baseline cortisol, how to interpret is if 8 a.m. cortisol is less than 5, it is significant for us. Or at the time of hypoglycemia, the cortisol was less than 18, it is significant for us. If it is all borderline, we are not sure, we have to proceed with the synaptin stimulation testing to prove adrenal insufficiency. Okay, so next slide.
Growth hormone stimulation test was done for the child with clonidine 0.15 mg meter square. Stat dose was given, and then blood sugars and blood pressure are monitored frequently with the sampling 30 minutes and 60 minutes was for this data. 30 minutes sampling was 30 minutes value was very high, and then 60 minutes value also high with the fasting sample that is also high.
Okay, so our growth hormone values have all come high. So what is your interpretation of this?
Growth hormone is very high with very low IGF-1 levels, which is indicating that growth hormone axis is intact, but the receptor action is not functioning well.
Okay. So there is resistance. Okay, so growth hormone resistance is there. So what is your diagnosis?
This is a growth hormone insensitivity.
Yeah, growth hormone insensitivity or the Laren's dwarfism. So suppose the growth hormone levels are coming 4, 3 like that, then what will you think of?
Again, pituitary axis is not.
So that is growth hormone deficiency. So what is the cutoff you use for complete growth hormone deficiency and partial growth hormone deficiency?
Less than 10 for
10.
Okay, so less than 5 means complete growth hormone deficiency. 5 to 10 means partial growth hormone deficiency. Okay, so next slide.
We proceeded with the clinical exome sequencing because we considered a growth hormone receptor sensitivity, and she was evaluated. And genetic studies were suggesting homozygous mutation, autosomal recessive, involving the growth hormone receptor in exon 7, indicating Laron dwarfism with IGF.
Okay. So the genetic confirmation of your diagnosis is also done. Okay. So you can proceed with the treatment. Yes. Dr. Hemchand, sir, you can carry on.
Thank you. I think one person has been silent, Dr. Anvita. So how should we treat this child, Anvita?
Because there is growth hormone insensitivity and this is an receptor defect, there is no point in giving growth hormone levels. Hence, growth hormone IGF-1 can be given for the treatment. Sir.
Very good. So you have mentioned this dose in this slide, and what is the important side effect of recombinant IGF-1? You mentioned here you monitored for that also. Hypoglycemia, isn't it?
Hypoglycemia.
Hypoglycemia. So they should be taught about recognition of hypoglycemia, tackling and importance of regular monitoring for hypoglycemia. And that is why, do you give it before meal or after the meal?
Before the meal.
No, after the meal. Yes, you mentioned in the slide 15 minutes after the meal, isn't it? To avoid a hypoglycemic episode. Very good. So very beautifully presented case of a child with pathological proportionate short stature. So you can sum it up after a while, Dr. Sandeep. So Dr. Anvita, some quick questions for you. Standardly asked questions. What is the treatment for growth hormone deficiency? One liner.
Growth hormone can be given, sir.
Very good. What is the dose of growth hormone?
Usually it will be like 0.1 units per kg per day.
Okay. And
It
what the
depends.
Yeah, very good. Depends on the indication. 1 unit once a day, or how many times in a day?
Usually once a day, sir, particularly in the evening times.
Very good. And what is the route of administration?
Subcutaneous.
Very good. And why do you specifically want to give it in the evening?
Because the physiological secretion of growth hormone will be more during the evening times, and it will correlate with the physiological.
Excellent. What are the common side effects of growth hormone?
There will be fluid retention, and edema will be there, and increases the glucose levels. Hence, HbA1c should be monitored regularly.
Okay. Headache,
And,
vomiting, isn't it?
Headache, vomiting, benign intracranial hypertension will be there.
Sometimes gynecomastia also, isn't it? What are the non-growth hormone indications for non-GHT indications for growth hormone? Other indication for growth hormone treatment?
Turner's.
Very good. Turner syndrome, SGA,
Prader-Willi.
Prader-Willi syndrome. Excellent. And Prader-Willi syndrome, SGAs who don't catch up, Turner syndrome, shocks, etc. Very good. So, Dr. Anvita, what is the treatment for familial short stature?
Familial short stature, usually we don't treat it. Usually counseling the family and social support.
Very good. Growth monitoring, isn't it? So, what are the clues to evaluate or treat a child with growth familial short stature? Red flag signs. Poor growth velocity, isn't it? So, what is usually
growth velocity, falling growth velocity during serial monitoring.
Excellent. So, poor growth velocity or a delayed bone age may be a clue for a possibility of maybe familial growth hormone deficiency, isn't it? If the growth velocity is normal and if the child is growing well and has a normal bone age, would you treat the child?
No, sir.
Excellent. Okay. So what is the treatment for constitutional delay of growth and puberty?
CDGP, usually they'll catch up after a certain age, but because this puberty will also be delayed, we can give it testosterone and accelerate the puberty.
Excellent. Right? You can kickstart the puberty in especially boys who do not have signs of maturation beyond 14.5 years of age, isn't it? This is the standard guideline given in Nelson. Above 14 years of age, no features of maturation and significant psychological distress. Boys who are worried, my friends are growing, those are the boys who have psychological distress. They should be treated with testosterone. Not everybody. Right. What is the treatment for hypothyroidism, Dr. Anvita?
Thyroxine supplements can be given, sir.
Very good. Those?
For first 5 years of age, it will be 5 microgram per kg per day.
Okay. For this child,
and as the age advances, the dose will be decreased.
Okay, very good. For this child, 6 years, 10 months, how much do you want to give? 13 kilos?
Around 5 microgram per kg per day.
Okay, 3 to 5 microgram per kg per day. Right. For Turner syndrome, what is the treatment?
Growth hormone supplementation.
Okay, growth hormone replacement, growth monitoring, sex hormone replacement also can be considered if they have delayed puberty, isn't it? So growth hormone, is the dose same as growth hormone deficiency or is it different? Slightly higher, isn't it? Growth hormone deficiency, it's as you said 0.1. In this one, it is slightly higher. It is 0.14 IU per kg per day. What is the dose of growth hormone replacement in milligram, Dr. Anvita?
Usually 1 milligram will be equal to 3 international units.
Very good. 1 milligram is 3 IU. So you have to calculate that, and you can give it as milligram as well. So is there any treatment available for skeletal dysplasia?
Skeletal dysplasia, conservatively we cannot, I mean, there are certain surgical procedures where there will be bone lengthening will be done.
Limb lengthening procedure after growth and puberty is complete. Very rarely, of course. Newer treatments, shocks, gene defects can be treated with growth hormone therapy. Then achondroplasia, there's a new drug called as vosoritide that can be tried to improve the growth velocity, isn't it? So these are some of the emerging treatment modalities for skeletal dysplasia. And so these are the various treatment aspects of growth hormone and treatment of various causes for short stature. So now for quick commonly asked questions, I'll just keep alternating between the three of you. Dr. Anvita, what are the endocrine causes for short stature? Anvita?
Yes, sir. Hypothyroidism.
1.
Cushing syndrome.
2. Common, what is this case? Very good.
Growth hormone deficiency.
Okay.
Pseudo-hypoparathyroidism.
1 more. Poorly controlled diabetes. Okay. Right. Dr. Sandeep, what are the syndromic causes for short stature that can be treated with growth hormone?
Turner syndrome, the Prader-Willi syndrome.
Very good. Right. Okay. Very good. Very good. And Dr. Mitra,
Yes,
what are the
yes.
normal variant short stature? What are the causes?
Familial short stature and CGDP, which is
Can you describe the growth chart of CDGP?
CDGP children will be always passing along the third centile, sir. They'll be less than third centile, but they'll be touching the third centile. And at one point, the target height will be normal for them. They'll reach the target height at a particular point.
What point? Slightly delayed, isn't it, compared to their peers? So they enter into puberty early. They have a spurt late, puberty late, and they have a spurt little later. Ultimately, reach a height acceptable for the target. Excellent. And you said about the growing years, they are close to the third percentile. What about at birth? How are they?
At birth, they are like normal.
Excellent.
Normal height.
Very good. So, Dr. Sandeep, when would you worry about a child crossing percentiles?
The child is crossing more than 2 centiles, crossing below more than 2 centiles in 6 months, where the child is below 5 years, or more than 2 centiles, falling below more 2 centiles in a year, the child is more than 5 years.
Excellent. Crossing of 2 major percentiles in a short while, 6 monthly during early phases, and in a period of 1 year in an older child, you would worry. Dr. Mitra, can you tell me some common causes for catch-up, for crossing of percentile lines, which you would not worry?
One is this delay, CDGP, so that
Excellent.
growth and
Excellent. Anything else? Familial short stature. They are usually normal at birth. They slowly cross their percentile lines and they come and reach their target height percentile line. But that will be done very slowly, won't be done very rapidly. And SGA babies, when they catch up growth and they reach the normal percentile, they may have to do some crossing of percentile lines. Any child who had an acute illness, lost a lot of weight, like anorexia nervosa, diabetes, DKA, they are catching up, they may cross some percentile lines, and you need not worry about that when you know that is a cause. Dr. Mitra, can you name a drug which can cause short stature?
steroids.
Very good.
Steroids can usually cause.
Okay, okay, right. And Dr. Mitra, how would you approach short stature in a child with CKD? Mitra?
Yes, sir. Yes, sir.
CKD with short stature?
We can give growth hormone.
Very good. I mean, that would be the last answer. I would first like to correct the anemia. I would like to correct acidosis.
I would like to improve the hemoglobin levels. I would like to improve the electrolyte levels. Those kind of correctable factors. I would like to correct the puberty. Those kind of factors, correct the vitamin D level. I would like to improve the bone health. Those kind of parameters can be done first. And then ultimately, if there is no catch-up, despite, and of course, a transplantation in a chronic kidney disease. And despite that, if there is no catch-up, one can consider growth hormone replacement. Very good. Dr. Sandeep, how would you approach short stature in a child with thalassemia?
Thalassemia child will receive multiple number of transfusions that will cause iron overload. That will affect bone health, and that will affect the hormonal axis also, including thyroid and pituitary axis. So we have to chelate the iron overload, and then we have to treat the child.
Very good. You have to first optimize iron levels, and you have to very importantly screen them for complications, endocrine complications during the adolescent phase, and monitor the growth, isn't it? That is very important. If needed, you may have to start them on hormonal replacement therapy. Very good. Right. And Dr. Mitra, can you say a few words about the new pediatrician-friendly growth charts? So the new pediatrician-friendly growth charts are one, as mentioned by Madam. They are ones where you need not calculate the target height. Just join the points between the father's height and the mother's height. Target height percentile will be arrived at. It's mainly for practitioners, not for exam purposes. Okay. Dr. Sandeep, is stunting and short stature same?
No, sir.
How is it different? I think it's a very dicey question. This is a very dicey question. There is no clear answer to this. From a more epidemiological perspective and from a more community perspective, stunting is a terminology that is used. And short stature is most from a clinic-based or a hospital-based definition. Technically, both of them are height below the third percentile. But the perspective of application of the definition is different. Generally, children less than 5 years, stunting is the terminology adopted by the WHO. Older children, IIT says, stick on to short stature. So I think they are interchangeable. More a community perspective for stunting and a hospital or a hospital-based definition for short stature. Okay, Dr. Anvita, how would you diagnose SGA at birth? What charts would you use, and what is the definition of SGA?
Weight less than 10 centile will be small for gestational age babies.
Yeah, very good. You have height, weight, length, weight, or head circumference below 2 standard deviations. And what charts would you use to make the diagnosis?
Fenton charts will be used usually for SGA.
New Fenton charts can be used. There is also a lot of popularity about the intergrowth 21 charts that are also being used to make a diagnosis of SGA. Okay, so right. So what do you mean by corrected gestational age, Anvita? If you have a child, yeah.
For preterm babies, there will be postnatal age and postnatal age will be added.
Very good. So you have to calculate the birth from the EDD. So the chronological age minus the expected date of delivery will give you the corrected gestational age. So would you plot the growth for the chronological age or the corrected age? Anvita.
Corrected age, sir.
Very good. Till what year would you use that?
2 years.
Excellent. Till 2 years, you have to use the corrected gestational age. Dr. Mitra, can you rattle out the causes for disproportionate short stature?
Yes, sir. For disproportionate short stature, they can either have short trunk, like in cases of mucopolysaccharidosis, classic example is MPS, and or they can have short limbs like hypothyroidism or achondroplasia in those
short limbs. How will you classify it further?
Acromelia, mesomelia, rhizomelia.
Very good.
Yes,
yeah, continue.
Yes, sir. So for rhizomelia, example is achondroplasia, and for acromelia, Ellis Van Creveld syndrome.
Very good. For
For
mesomelic,
mesomelia, mesomelic dysplasia.
excellent. Very good. Very good. So, Dr. Sandeep, we have a child with short stature who is not affordable for any treatment. Would you like to investigate this child? They cannot take, they are not willing for growth hormone. You still like to investigate the child?
First, you have to rule out the physiological causes, sir. If the child is pathological, means definitely we have to investigate.
Very good. See, there are a lot of treatable comorbidities that have to be rectified. For example, Turner syndrome may have a cardiac abnormality which has to be corrected. Hypopituitarism may have cortisol deficiency which may be life-saving. So they may have short stature that needs to be rectified beyond growth. Child may be having a craniopharyngioma with hypopituitarism. The child needs a neurosurgical intervention and vision preservation, isn't it? Right. So, Dr. Anvita, how would you treat a baby who is born SGA and has no catch-up?
SGA babies will be usually having growth hormone insensitivity, sir.
Okay.
So IGF-1 supplementation will improve the.
See, that will be very tedious. Definitely, yes, they have some amount of growth hormone insensitivity in the initial years. But generally, currently, there is a concept that if they don't catch up beyond 4 to 5 years of age, and their height SDS is below minus 2.5 SDs, then they may be a candidate for growth promoting treatment. But provided you have improved the nutrition, you have ruled out other treatable causes, and importantly, you have ruled out conditions which are a contraindication for growth hormone. That should be definitely be like Bloom syndrome or Fanconi syndrome, etc. Right. Dr. Sandeep, tell me two causes for delayed bone age and short stature.
CDGP, sir, constitutional delay in growth and puberty. And then hypothyroidism.
Very good. Right. So, and Sandeep, would you be able to tell the different Tanner stages? Can you describe Tanner's stages 1 to 5 in boys and girls?
Yes, sir. In girls, stage 1, the breast development pre-pubertal, only myelination of papilla with no pigment, with no pubic hair. Stage 2, slight budding with slightly palpable or elevated breastbud will be seen, and pigmented hair may only in the label area in the stage 2. And stage 3, both areola and breast will be enlarged, and there will be pigmented hair over the labia majora, and then slightly in the pubic area also. And stage 4, secondary mound of there will be a elevation and secondary mound formation with the adult type pubic hair. And stage 5 is mature pubertal height with adult type of hair distribution and breast development.
Excellent, Dr. Sandeep. I think Dr. Mitra, can you describe it in girls?
Girls?
Yeah, I'm sorry, in boys.
Boys. Sir, in boys, the main 3 things we have to look for is volume of the testis and pubic hair and penis. Sir. And in stage 1, there'll be pre-pubertal stage. There won't be any pubic hair, and the testis volume will be like in pre-pubertal stage. And in stage 2, there'll be like enlargement of testis, and the hair will be like long hair, and usually it will occur after the testicular growth, this hair growth. And in case of stage 3, there will be further volume enlargement of the testis and significant increase in the penile length, and the hair will be like more curling now in case of stage 3, sir. And stage 4, again the testis volume will be increased. Here it will be around 20 ml, which was initially 4 ml in stage 1. And this penis and pubic hair will reach the adult type. Adult type of pubic hair will be seen. And in stage 5, the
Or
adult
the penis?
like penis will be enlarged, sir, and
Glands may appear.
glands. Yes, sir.
Okay.
And in stage 5, the adult volume of the testis will be reached, and everything will be in adult hair, and the distribution of the hair will be of the adult like adult.
Very good, very good. And what is the average growth spurt had by an Indian girl and an Indian boy?
Indian girl will be like 9 to 10.
Not per year. I'm talking about cumulatively how much height do they gain during puberty? Totally.
Okay, sir. No, sir, I don't.
And boy will reach up to 160 centimeters average in between. And,
no, how much they gain?
And 10 to 12 centimeters per year in the boy.
Cumulative, totally during the pubertal process. Right. Okay. See, I think what are the red flag signs of endocrine cause for short stature from a growth chart, Dr. Sandeep? What is there in your case? Same thing.
The height is more affected, more than -2 below, falling below more than -2 standard deviation, and crossing 2 major centiles within a 6 months in a child. And previously, well growing child suddenly falling with the faltering of the growth after an illness,
usually what is considered height below -3 standard deviations, growth velocity below the 25th percentile, and a bone age delay of more than 2 years. So some commonly made mistakes, very commonly made in the exam, is choosing the pink chart for boys and blue chart for girls. That should definitely be avoided. Target height should properly be plotted, at least attempted to be plotted. Target range is 6 centimeters, not 8.5 centimeters. So I think these are the common mistakes that all of us tend to make during the examination in the hurry. So I think I tried to quickly say and commonly asked FAQs as such. Now I think I hand over to our moderator, madam, to take it further.
Gathered by not just marking it correctly, but also how much of information can be got by interpreting them properly. Okay? And also the importance right from the prenatal at birth, what the size is, so as to come to some kind of a conclusion. Thank you both, Dr. Soundram and Dr. Hemchan. Just a few words, as we said, documentation, birth records, and knowing all the anthropometry is very, very important. The velocity should be monitored, and assessment of MPH is very important. We cannot just label a child as short unless and until all the criteria which we have repeatedly mentioned in the last 2 hours should be satisfied, and we should know which growth chart to be used at what particular age. So, and this I think has been discussed. We always, when you see a child with short stature, you need to see first whether is it normal, is it pathological. If it is normal, whether it is just a familial short stature or whether it is a constitutional delay in growth and puberty. And if it is pathological, you need to see is it proportionate or is it disproportionate. If it is proportionate, then you will think about genetic syndromes, chromosomal, nutritional, endocrine, and chronic systemic illness. If it is disproportionate, then we always think in terms of skeletal dysplasias. So I think, yeah, these are just a few close, doesn't always hold good, but very important whenever we see a girl child with short stature, we need to rule out Turner syndrome. And a complete examination right from the front and from the back, including the spine and the side, should be examined, because a small minimum webbing of the neck can only be made out if you see the child from the back. So these are a few things that we can't miss, and the entire maneuvers which are given in the books should be done for all children with short stature. Yeah, these are the maneuvers which is there given in all the books. So we can come to some kind of an idea if we could do all this just like we do P-GALS in skeletal system. These small maneuvers would also help. I think you can close the screen, Sandeep. If there is time, you can just display the growth charts.
Okay.
I think everybody is familiar
Yes,
with these charts, and I
yes,
think
ma'am.
Dr. Hemchand has very clearly said how to plot, how exactly to interpret. I think everything has been very clearly mentioned, and I'm sure now all the students will be able to do this and should do it every day in your OPD practice. And use the right color, like how he said. Otherwise, definitely the interpretation will also be not correct. Thank you. This is the pediatrician friendly growth chart, which we have already mentioned. It's very simple. You just plot father's height and mother's height and just see the centile and just see how far behind the child is. So that will give you an idea about growth faltering. Similarly, you also have a very simple chart to mark the BMI. Here you have the height of the child, and here you have the weight of the child. So for this height, if the for this height, if the child's weight were to be somewhere here, you know that the child is obese. So you don't really need to calculate the BMI. But these are only quick reference and only for office practice. I think this has also already been mentioned, how to calculate the target height from the MPH and how to plot it.
That's oh.
I think over to the Dr. Rajendra.
Yeah, you can stop straight side, Dr. Sandeep. Yeah, excellent presentation by Dr. Sandeep, and deliberation was good, so good with Dr. Hemchand and as well as Soundarya. Soundaram. And now I request Dr. Srinivasan to come in place. Sir, Srinivasan, sir.
I already posted my comments.
Yeah, you
I already posted in the chat box my comments. So others can answer.
Okay. Next, Dr. Ramesh, sir. Dr. Ramesh, sir. Okay. Dr. Rama Chandramohan, yeah.
Yeah, good evening to all of you. It was, undoubtedly it was a very delightful discussion. Short stature is something which is actually very theoretical, but everything was discussed so well, starting from Dr. Lalita's presentation and Hemchand and Soundram. And I like the last part where Hemchand was this rapid fire round. It was very nice where they made them think, and the PGs, they would have looked like it was all rehearsed the way they were ready with the answers for each of those questions. Good on you, PGs. You have done a very good job. And on the whole, it was a very interesting, and Hemchand and Soundram and Lalita ma'am, excellent.
Even if they are rehearsed, they have done a very good work.
That's what I'm saying. I mean, it's obviously not rehearsed, because I know Hemchand was just pulling out questions from his hat, and these PGs came up to that. Excellent.
Dr. P. Ramchandran, sir, please.
Thank you. As already mentioned, it was a delightful presentation by the postgraduates. Very nicely done. And Dr. Soundram and Dr. Hemchand are covering all the aspects. See, it is not only for them, it is for every one of us. What are all the things we had to look at in a child who is presenting with short stature, how we should approach. So it was a great learning experience for all of us. And all the practical aspects are covered. See, there are so many advances in the growth charts which have been brought out by IAP, and each one has got a special significance. And I liked especially the way the Hemchand was able to bring out all the important aspects of the weight age, height age, and bone age, vis-a-vis chronological age, and how to distinguish based on the growth chart. So that was extremely useful. And the PGs rose up to the occasion. So, and this is one this thing when Hemchand did not allow any one PG to just take rest. So all of them had to be on their toes. So they had to, he was just posing questions like
They already made up their mind to take up endocrinology.
So he's a kind of role model where all the people would like to do that. So it's a delightful experience. So thank you so much. Thanks, Dr. Soundram, Dr. Hemchand, and Dr. Lalita for summarizing everything and bringing out all the important aspects of it. And once again, congratulations to the PGs for the wonderful presentation and discussion. Thank you.
Dr. Janani, madam, please.
Yeah, I think it's our own institution. I cannot really comment. They did really well. I think Hemchand and Soundram added flavor to the presentation. And of course, Dr. Lalita did a wonderful job by summarizing everything. I think every Saturday we learn, sir. We've become like studious students who will log in and listen. And we forget that we are judges. We just Mudiyor Kalbi.
Yes, especially today.
You are not Mudiyor, you are looking young, madam. Don't say you
Sir,
are Mudiyor.
we are all Mudiyor, sir. All parties.
You can refer to me as Mudiyor, but not to you, though you are a grandmother.
Yeah. So anyhow, I mean, senior learning or whatever it is, we enjoy. I mean, thanks to Rajendran sir for making us judges, because we log in on the dot at 7:30, and last week was excellent. I would like to talk to that Kritika. I learned so much from her last week. It was really good. Every week after week, it's really nice. Students do well. The people who discuss, the examiners and the consultants and the moderators, all of them are doing a wonderful job. I think we should congratulate Dr. Rajendran for finding people and putting them in place. I think, sir, it was
you are improving the quality and quantity, this thing of education.
Yeah, it's really good. I wish
Thank you,
students log in
Rajendran. We
and
can
benefit.
be feeling proud.
I wish students log in and benefit, sir. That is what we all look forward to. Yeah.
It's created
Thank you.
academic
Yeah.
tool.
Yeah, it's available
Yes.
IAP TNSC website, madam, and anytime you can go and see that.
Yeah,
it's available.
But to get to hold of people who are really
And
pioneers,
that is true, but
that,
anyhow, listening to the, rather than seeing the video, is much more information.
live discussion, listening to
live
live
discussion, and
is
the way the questions are asked and the way the students respond, it motivates other students also. Of course, anytime, as you said, it's available for viewing. Those people who have missed, they can always see. But if you tell that, then people will not join in to see PGs. Only people like me will come. So don't tell that, because there are so many other interesting things in their life.
On a Saturday.
Yes, Thank you so much.
Actually, the individual institutions, the faculty can make it known to their own PGs, because they may not be accessing any of the groups like DAP and other things.
We usually tell them, sir.
Yeah, probably
we usually post it in the class students group and inform them.
Yes.
In fact, people there are from Rishikesh, students from Rishikesh are listening to our sessions every week, sir.
You have to thank Janani also, because most of the time Janani is not there at the end to give her comments. But today she is there to give her comments. So thank you so much.
Today I'm awake. Because it's our institution, I have to be awake. Thank you, sir. Thank you.
Thank you, madam. And Dr. Hemchand, please, your concluding remark. Unmuting, Dr.
Thank you, sir. Thank you very much for the opportunity. Thank you.
Hemchand, we enjoyed your
Thank
you very much. It was a great learning experience even for all of us.
Thank you, madam. Thank you very much. On behalf of IAP TNSC, I thank today's chairperson, Dr. Lalita Janagiraman, and moderators Ramchand Prasad and